Well, the higher or the bigger or the more severe the problem, the more activation of the bone marrow. And even though it takes more or less 1 to 2 days for the erythrocytes to mature in plasma and exert its full function, there is a high risk or probability that the patients would have immature cells that hasn't gone through the entire cycle of maturation. So one of the indicators that the bone marrow is active and fully competent and is responding to the major insult, which is bleeding, okay, is the presence of reticulocytes in plasma. So reticulocytes are an indicator of health or healthy bone marrow, and are also an indicator that if you provide treatment for the patient, for example, I'm now giving a cofactor, vitamin B12 or iron, or I'm giving blood, okay, that the less anemia the patient will have, the less reactive the bone marrow will become, and of course the reticulocytes will decrease, right? So it's an indicator of treatment, and it's an indicator, if they're elevated, that the bone marrow is active. Because do you think that if the bone marrow has cancer, such as leukemias and lymphomas and multiple myelomas, or Burkitt lymphoma, any malignancy within the bone marrow will get up to the time of maturation? Not even reticulocytes will be formed. The majority that will be in plasma will be in mature form. So if you ever see a large amount of blast or immature cellularity, and even only pluripotential stem cells in plasma, that's an indicator of malignancy, okay? So instead of looking at platelets being formed, you have a large amount of population of platelets, but it will not be thrombocytes. Most likely it will be either megakaryocytes or megakaryoblast, completely immature. Anything, any cell. Instead of looking at lymphocytes, you're gonna have a large amount of lymphoblasts if you have lymphocytic leukemia, for example. Do you understand? But if you have, for example, a viral infection that you know lymphocytes are highly produced in a viral infection, you're going to have a large amount of lymphocytes, but mature. Do you understand? Good. So going back, reticulocyte count, when it's present, is an indicator of that the bone marrow is working properly, right? Either because there is a major cofactor deficiency that you're providing, or because the patient's having an acute bleed and the bone marrow is active, okay? We went through the major causes. For example, you have, as I said, you have an MCV less than 80 and an MCHC less than 32. Most likely you have, what are the possibilities? The most common is, again, iron deficiency anemia or thalassemia, right? If you have an MCV that is normal, which is 80 to 100, and an MCHC of 32 or 36, you have a normocytic pneumochromic anemia. So the most common causes are anemia of chronic diseases. Tell me a disease. CKD? Why CKD is the most common chronic disease that is applicable for normocytic pneumochromic? Because not only we need iron, not only we need vitamin B12, not only we need vitamin C, not only we need cobalt, but we need erythropoietin or erythropoietin, right? At the level of the renal cortex that is released to be able to have a normal or healthy hematopoietic system. Okay? But it's not exempted. It's not the only one. Any chronic disease, autoimmune conditions, rheumatoid arthritis, lupus, cancers, or even the treatment for cancer, chemotherapies, can induce normocytic pneumochromic anemias. Anything that you can imagine chronically can induce anemia of chronic disease. Yeah, hypo, hyper, thyroidism can induce normocytic chromochromic anemia. Okay? Having an MCV high, which is again your MCV greater than 100 and your MCHC greater than 36, what's going to provide? This is folic acid deficiency, vitamin B12. But again, it's anything that can affect, because if you have, for example, a patient with lead poisoning, which you're going to study in 669, can induce this as well. So any cofactor necessary for the hematopoietic system to work properly could induce macrocytic normochromic anemia. Now, you will see that alcohol abuse is highly linked with folic acid deficiency, okay? And remember that vitamin B12 deficiency is also called pernicious anemia. This is another example of what I just told you. So instead of having already your erythrocyte mature, is expected that if you have a massive hematemesis or a patient with a trauma, okay, or rupture of any major artery. For example, you have a patient that went for cardiac cath, and unfortunately they produce a fistula in the femoral artery, and now the patient has a retroperitoneal bleed. That retroperitoneal bleed can induce elevation of reticulocytes. So you might have that in the peripheral smear, okay? Instead of having a large proportion of erythrocytes in the peripheral smear. So that's okay, that's normal, that's expected. Okay, but if you don't see that, not only the patient has a rupture, a fistula of the femoral artery, but some background malignancy could be going on as well, okay? So let's talk about bilirubin, that even though we have it in pathophysiology as well. Bilirubin is basically formed as a pigment from the breakdown of the erythrocytes. So whenever the red blood cell goes through hemolysis by any reason, there's release from the hemoglobin, a pigment, right? Which is called bilirubin. The bilirubin has to be excreted through the urine, through the feces, and through the skin. So before the liver, what goes to the liver is the hepatic artery, right? And who provides blood supply to the hepatic artery? The heart, the blood. So if you're losing blood due to hemorrhage, or you're losing blood because you have hemolysis or breaking down of red blood cells, or if you don't have enough blood because the patient's cardiac output is compromised, or if you don't have enough blood because by any reason the patient's bleeding, you can have bilirubinemia, right? But that would not be related to liver conditions. So that would be pre-hepatic. And what you would see in plasma will be indirect bilirubinemia, even though the total, of course, would be elevated. But it's based on unconjugated bilirubinemia because the bilirubin is combined with an enzyme in the liver. Okay? Now, what can give you intrahepatic? Anything that affects the liver. Can right side failure affect the liver? Yes. So after you have hepatomegaly, and that has hepatic congestion, and the patients have hyperbilirubinemia, that is intrahepatic. But if you have hepatitis of any kind, that will give you intrahepatic. If you have cirrhosis of the liver, that can give you intrahepatic. Hepatocellular carcinoma, that can give you intrahepatic. If you have anything that affects the liver directly or indirectly, or an obstruction of the conducts that will lead to or leave the liver, such as the duodenum, the pancreatic duct, the gallbladder duct, which is a common bile duct, obstruction, combine the calculi, that could also give you direct bilirubinemia, even though it's post-hepatic. Duodenitis, pancreatitis, cholecystitis. Okay? So the patient will have exactly the same symptom, which is jaundice. But that will be based on direct, conjugated. And it's important for you not only to do liver profile, but look at your bilirubins, indirect and direct, to be able to determine the cause of that patient. Now, in addition, whenever there is hemolysis, guys, think through. If you don't have enough blood, enough volume, enough oxygen going to the cell will go into what? Anaerobic metabolism and production of lactic acid, right? So lactic dehydrogenase elevated in blood is not only sepsis, is any single condition that the amount of blood supply or oxygenation to the tissue is compromised. So having elevation of lactic dehydrogenase is an indicator of hemolysis. Okay? It could be acute bleed by any other source, but we take it as guidance as the cell is going through hypoxia, and combined is basically less sensitive by itself, because any disease process can give you elevation of LDH, right? That goes through hypoxia. But if you combine it with haptoglobin, which is only secreted when the red blood cell is going through a breakdown process, is more specific for hemolysis. Okay? So elevation of haptoglobin, elevation of LDH, and elevation of indirect or unconjugated bilirubinemia is are highly indicators of hemolysis. This is the entire metabolism of bilirubin that I kind of explained already. Now, normally, as I said, the bilirubin is excreted through the skin, the feces, the urine. But as a pigment that has to be excreted, when it's accumulated, it's toxic. So if it goes through the brain, you can have neurotoxicity, what's called connectures, even though it's most common in pediatric patients, it could happen in adulthood. So patients have altered mental status when they have hyperbilirubinemia. It's secreted the excess amount, or the normal amount, but it's secreted in the skin. So when the patients have hyperbilirubinemia, they have pruritus. It's also excreted through the urine and through the feces. Now you might see two different scenarios. When the patients are having indirect bilirubinemia unconjugated due to most likely hemolysis or decreased cardiac output, right? Or decreased volume because the patient is bleeding, most likely, or CHF, right? When the liver is not congested yet, normally the patients would have hypercholoric, meaning that high color urine, brown, dark, and the feces as well. But in clinical presentation, when you have an obstructive case, meaning that you either have nodular cirrhosis, right, that are obstructing the ducts of the bile, pancreas, or duodenum. Now you have a cancer, or major duodenitis, you have pancreatitis or pancreatic cancer, or you have a major stone obstructing the common bile duct. Where's the bilirubin going through? Only through the skin and the CNS. But can it go through the urine? No. Can it go through the feces? No. You might not see the change in the urine because some patients can have crystal clear urine, right? But what about the feces? Those feces will be completely acholic, meaning that no color, white. Okay? So that's a clinical indicator, huh?
That's the right.
Most likely will be present. So this is exactly what I just went through, okay? So you have a patient with pre-hepatic, any type of hemolysis, sepsis, decreased cardiac output, any major hypovolemic episode due to bleeding, You expect unconjugated hyperbilirubinemia, but still the patient has jaundice, right? Or icterus, it's called like that. There are many congenital anomalies that can give you that as well, that again gives you red blood cells abnormalities that they can pass through the capillary and rupture, and that's the reason why they can also have hyperbilirubinemia. Now, you have conjugated hyperbilirubinemia, either intrahepatic or post-hepatic. Well, let's analyze. What about if you have hepatocellular carcinoma? What about if you have, for example, fibrosis of the liver due to cirrhosis, hepatitis, cholangitis, pancreatic carcinoma? What about if you have any type of obstruction of the ducts that connects to the liver? What about if you have, again, pancreatic cancer or cholecystitis? Cholecystitis you would see in GI in 668, that you could have two types, calculus or acalculus. Calculus cholecystitis is you actually have a stone, okay? But acalculus cholecystitis, when the patients are in critical care or going through a critical care condition, the amount of bile, well, first of all, you have the patient on NPO for a little while, right? Even though the guideline says start as soon as possible. But if by any reason the patients are fasting for actually more than 48 hours, there's a high risk for stagnant bile, and that could obstruct the conduct and produce cholecystitis retrograde without the presence of calculi. So I don't know if you have seen, but I have seen, and it's written in the literature, in the book, that any patient, for any reason, that are in a critical stage, for a prior condition, okay, they can have a complication of acute cholecystitis, and when you do an ultrasound or CT scan of the abdomen, there's no presence of calculi. But still, you have to drain that gallbladder either by cholecystostomy or cholecystectomy. So that is called acalculous cholecystitis, okay? But still can give you direct bilirubinemia with total and the presence of inflammation of the gallbladder, okay?
Pancreatitis will give you
Direct. Normally pancreatitis doesn't give you jaundice, okay, unless there's a major obstruction or severity based on random score. You can study that in GI. Most likely, of course, it will give you elevation of amylase, lipase, and liver function tests, but never to the point of giving you hyperbilirubinemia and jaundice. But it could be. Why? Because if at any point the pancreatic duct is obstructed, it could induce it. Now, these are other classifications of anemia. It could be hyper or hypoproliferative. That's based on the bone marrow. If you have a myeloproliferative disease, such as, again, leukemias and lymphomas and multiple myelomas. If there is any ineffective erythropoiesis, most likely for the same reason. If there's major hemolysis or acute bleeding, or again, the most common that we use in clinical practice as well as in board examination is macrocytic and normocytic. Okay? Now, what are the hypoproliferative anemias that we can see in clinical practice? As I said, we're going to study the most common, and that doesn't mean that, for example, lead poisoning is not important, but we can leave this for NUR 669, which you would have the toxidromes presented to you, okay? Such as aspirin toxicity and lead toxicity and organophosphate toxicity, etc. Okay? Tylenol, opioids, all that. Okay? So anemia of chronic diseases can induce that. Aplastic anemia, we're going to go through it. And anemia of chronic diseases and nutritional deficiencies as well. We have an entire presentation for you in next semester. Now, microcytic pneumochromic anemia, as I said, even though microcytic hypochromic anemia, the most common is iron deficiency anemia, I want you to remember that the iron to be deficient, you're either not consuming it appropriately, you're not absorbing it appropriately, or you're losing it through the intestine. Very, very uncommon in our country due to the resources that we have, that patients will be iron deficiency anemia by malnutrition, even though the more, I'm not criticizing any type of diet or nutritional habit, but the less amount of meat that you consume or iron sources that you consume, the more deficient you will be with iron. For example, vegans, okay? So if you have an extra source of iron supplementation, that would be okay. But another way of obtaining iron deficiency anemia is even though you are consuming it appropriately, it's not absorbing it appropriately. So if you have, for example, patients with ulcerative colitis, Crohn's disease, or irritable bowel syndrome, or any type of digestive, problems that the iron is not getting absorbed, you could also have iron deficiency anemia. And the most common in elderly population, even though it could be present at any age, is the chronic blood loss of iron through the feces. And that's the reason why whenever you see middle-aged adults with iron deficiency anemia, the first diagnostic evaluation that you must do besides your anemia profile, which is the ferritin, the transferrin, and the total iron binding capacity, is the stool for clot blood, okay? Either by rectal examination and testing it or sending it to the laboratory. Other ways of losing iron, chronically, it doesn't really matter if you use 1 pack of Tampax every single menstruation. It doesn't matter the amount of menorrhagia that you would have, still, because you stop at any point, right? It is not considered acute blood loss. Menorrhagias, because it happens every single month, it is considered chronic blood loss, and that's the reason why abundant amount of menstruations by any cause, either physiologic or pathologic, it is in iron deficiency anemia. Thalassemia, this is most likely recessive condition, X-linked, that basically what happens is that it changes alpha or beta to be able to produce a proper RBC are deficient, okay? And the shape of the cell is very, very small, so therefore the amount of hemoglobin and iron is present, but it's in the periphery and it's not allowed to enter the red blood cell, and that's the reason why if it's not utilized, it's not absorbed, it's not used for the metabolism of the cell, and therefore that's the reason why it's considered microcytic hypochromic anemia. We're going to go one by one, okay? So sideroblastic anemia is another congenital condition. Basically, here what happens is that there is, even though there's a deformity of the shape of the cell, there is a pigmentation as well surrounding the membrane of the cell, not allowing proper micro and macronutrients to be absorbed and used for the metabolism of iron. Even though these patients have a proper amount of iron, but it's at the periphery, so it's not getting utilized, okay? Even though, and you would see it in your book, even though chronic diseases could induce iron deficiency anemia, because guys, think about it. Let's go over Crohn's disease. You remember Crohn's disease, you remember having an alternation of constipation and diarrhea, you remember having mucosity, right? Mucus being discharged in the feces, as well as blood, right? So if you have strikes of blood in your feces every single day, that's also considered chronic loss of iron, right? But I don't want you to think that way because otherwise you're gonna get confused. So Crohn's disease could be a cause of iron deficiency anemia due to malabsorption of iron. But the major causes that I want you to think is anemia of chronic blood loss. So, these two, even though they're present in pediatric population, thalassemia patients can grow through adulthood. So we can also need to know about the disease process and treat it properly. Now, every time you're missing, they put the patient on folic acid, they put the patient on vitamin B12, they put the patient on epogen. Because when you're missing a cofactor, doesn't mean that you are truly deficient in another, but eventually iron deficiency can induce the deficiency of the rest of the cofactors. So it's not wrong what you see in clinical practice, that even though the patient only has normocytic normochromic induced by decreased or lack of erythropoietin, it wouldn't help for the patient, even though they're not deficient, to give cofactors for the bone marrow to work properly, okay? So, going again, reviewing your laboratory data for iron deficiency anemia, remember, this is an MCV less than 80, this is an MCHC less than 32, but what else do I need to know? Your deposit, ferritin, your transferrin transportation, and your total iron binding capacity, right? So you need to know your iron level, that will be low, right? Your ferritin, which is the deposit. If you don't have enough money to put in your bank account, I don't think you will be depositing much, right? So your ferritin, which is your deposit, will be low. Then, in addition to that, of course, this is normally the width of the cell. It's going to be small, right? That's all common sense. What about the transferring, the transportation? It's going to be low, right? But what about the capacity of that transport mechanism? As I explained back, if you were my student, if you have 100 chairs here and only 25 students, which is the iron molecule that is low, what's the capacity of this room having 100 chairs and only 25 students to accept more? High. So that's the reason why the total iron binding capacity is high, which is a marker of difference between iron deficiency anemia and thalassemias. So as I said, so the possibilities of iron deficiency anemia, please have in mind that even though you are very intelligent, right? That even though malignancy, because what about if you have a uterine cancer? Will you bleed? What about if you have a colon cancer? Will you bleed? So even though malignancies could be a cause of chronic blood loss and cause iron deficiency anemia, malignancies are chronic diseases that most likely would give you normocytic normochromic, right? So don't get confused with that.
Can I ask you something to Dr. Leal about the menorrhagia? I think menorrhagia can fall into, it's a chronic blood loss, but it
Now, I understand your point. Let me see if I am able to answer your question before you ask. Completely. Now she's coming with the menorrhagia. Oh, professor, what about if I actually have a uterine cancer? And this is the case that the patient doesn't stop, that the hemoglobin is 5, and now I am transfusing, waiting for gynecological oncology to do hysterectomy.
It's still acute blood loss. Right?
It is acute blood loss in that case.
But it's still normocytic normochromic.
It is normocytic normochromic at that case. But this is a woman that, let's put the same uterine cancer, has uterine cancer. And of course, one of the signs of that will be abundant menstruations, right? higher than normal, if it doesn't go to the point of dropping your hemoglobin to the point of transfusion, it wouldn't be acute blood loss, it will be chronic blood loss. That's for clinical practice, okay? Now, what I want you to remember here is that acute blood loss, the patient is acutely bleeding, hematemesis, hematochezia. You got a trauma patient losing blood, right? Transfuse is acute blood loss, right? Hemolytic anemias are acute blood loss, and patients that have a stool called blood positive, that's chronic blood loss. The rest of the examples, since there's so much confusion, is for your clinical practice. Okay? So the treatment for iron deficiency anemia, you can give me oral, right? If the patient is able to absorb and able to use the oral route, otherwise, intramuscular or IV. And remember that it comes constantly as question, even though it is a rare way of administering iron, iron still in other countries and cultures come to this country that can be administered intramuscular. You must go deep into the dermis because otherwise it can leave a permanent tattoo if you don't know how to administer the iron into the muscle, okay? As I said, what's there? Super important. Whenever you see a patient with microcytic hypochromic anemia, think about possibility of occult blood loss. So do the full microcytic, okay? Now, as I said, there are many ways of interpreting the peripheral smear and your CBC, but I want you to concentrate on your NCV and your NCHC, right? So if your NCV is low, less than 80, you have, wait, because I'm kind of getting lost. Okay, of course. Iron deficiency anemia, your hemoglobin is decreased. What about your NCV? Less than 80. This is the size, right? So depending on the phase that you see it, if the pluripotential stem cell is overproducing, you can see it elevated or low. That's the reason why. If it's iffy, neutral, no. So iron, total iron binding capacity, since I don't have a normal amount of iron, my iron level is low, my ferritin is low, my transferrin is low, but my capacity high. Okay? Thalassemia, hemoglobin. Why hemoglobin could be normal or decreased? Well, first of all, it's really difficult to recognize that the patient has anemia if the hemoglobin wouldn't be low, right? Because depending on the stage that the patient is at, the hemoglobin could be normal. But let's imagine that we do have a low hemoglobin. So of course, in thalassemia, the hemoglobin is low, right? Your mean corpuscular volume, forget about the 70, is less than 80, right? So it's microcytic hypochromic. So we're not going to take into account this. Why does the iron level is normal too high? Even though it's not there, it's normal too high. Where's the iron? Where's the
It's normal to higher though. The total binding capacity. You have an
No. Oh, okay, wait. I thought it was iron level. So let's analyze iron, ferritin, transferrin, and total iron binding capacity. Okay? So, what about the iron level? Thalassemia, you have the iron in the periphery and it's not being used by the cell, but it's present. So it's normal to high, even though it's not being used. Okay? But the ferritin, the deposit, if the amount of iron is present outside and it's normal, okay, what should happen, let me tell you what should happen, okay, because again, the literature changes depending on the book that you read. What should happen is that if you have your iron outside in the periphery and it's not being used for the metabolism of iron, the amount of iron in the serum remains normal to high, but the amount that is being deposited is low.
But which one do we check in?
Huh?
In the blood, which one do we check? When you do
The same, and you check your iron level, you check your ferritin, you check your transferrin, and you check your total iron binding capacity. Okay? So if you have a normal to high amount in the periphery being accumulated, and it makes sense with the treatment. Think about the treatment. For iron deficiency anemia, you give iron. For thalassemia, you cannot give iron because the total amount outside is normal to high. If you give me more, it's not going to be entering the cell anyhow. It's going to be accumulating outside, and the patients can have iron toxicity. On the contrary, to be able to have the cell to be metabolized, you have to destroy the excess by chelation therapy. So the ferritin cannot be deposited, right? Transferring, which is another marker of difference, the transportation is there. It's available, but the iron is outside. Okay? Now, what about the total iron binding capacity? Even though the transportation is available and is not being used, since the iron level outside in plasma is so elevated, if at any point will enter the cell, it will be oversaturated. So that's the reason why it is normal to low. So I want you to remember, because I cannot mention the magic word, right? I want you to remember that the main marker of difference, of course, iron low in iron deficiency anemia, iron high, which is the most common presentation, in thalassemia, total iron binding capacity high in iron deficiency anemia, total iron binding capacity low in thalassemia. Yes. And we went through the discussion. Now, what will be the major treatment for thalassemia? This is a congenital condition. You cannot do anything against that, to fix that. So basically, chelation therapy, try to eliminate the excess of iron. Be careful with transfusion. Because the more RBCs, if you don't have a hemoglobin less than 7, which the value, the goal should be no higher than 8, right? To keep the hemoglobin on these patients. Avoid transfusions at any cost unless extremely necessary, because the more transfusions you give, the more iron load and the more iron toxicity the patients would have. If the patient has to be massively transfused, it has to be followed by chelation therapy. Okay?
I have a question. So the book said to have a regular transfusion schedule to make sure there's no
And then the guideline says, because your book, even though it's 2019, it was edited in 2016, so the guideline says that you must keep the hemoglobin at a range of 8, no higher than that, because the patient has to have high score iron level.
So then
Okay.
ignore that already.
All right, so I'm not going to read the pathophysiology. I told you already, this is a translocation of genes. This is a recessive condition. This is a mutation of the alpha and the beta chains, right? That's the reason why the iron is not absorbed. But the iron is present, okay? So we do have the representation of the alpha and the beta chains. And patients with alpha thalassemia, these are the patients that are more benign or less aggressive condition. They have less anemia. They have less chances of having, iron overload. And therefore, sometimes this goes completely asymptomatic through the entire childhood and life. Only is recognized when the babies are born, that that they do genetic test through the heel, right? Like hypothyroidism and all that. So one of the conditions that is checked is thalassemia. And even though some patients are positive for alpha chain thalassemia, they never manifest any type of anemias or any type of bleeding, okay? Now, beta thalassemia is also called major, so alpha is minor, beta is major thalassemia. These are the patients that have a higher possibility of having severe anemias and transfusions, and more, of course, possibility of iron overload and neurotoxicity. Okay? Which is called Kubi anemia.
There is some special population in
Mediterraneans, Jewish, Asia. Okay? Again, another explanation of the mutation. Why the trait is only 25% inherit. Little cartoons expressing that. So you have traits, you have carriers, and patients that could have the possibility of 50% of having the disease and manifest the symptoms, which is actually the thalassemia major, which is beta thalassemia. Okay? So Asian population, as I said, even though it could happen in African American, is highly common in patients with Mediterranean, like such as Greek or Italians. So look for that background as well. Okay. Now, this is again the representation of anemias and alpha and beta thalassemia as well. So if you have an overproduction of alpha chain, you're going to have, of course, alpha thalassemia. As you could see, is the end of the story because it's called minor thalassemia, rarely symptomatic, is most likely captured at the time of born. Now you have beta thalassemia. Of course, you're going to have more. Let me tell you what happens when you're born. When you're born, you have what's called hemoglobin F. Okay, even though the erythrocyte is as no biconcave, is not mature, there's a major transformation of hemoglobin F to hemoglobin A in the first 2 weeks to a month of life. Okay? And the reason why I'm telling you this is because there's a medication that we use to be able to transform the malformed hemoglobin into hemoglobin F, because even though it's immature, it has a better carrying capacity for oxygen. Okay? So that's the reason why the more problems with the beta chains to produce the normal RBC, the more possibilities you have to have immature red blood cells, which in this case will be fetal type of red blood cells, which is F. Okay? Because the body perceives, or the bone marrow perceives, that since they have a better carrying capacity of oxygenation, they keep it immature. Okay? So, as I said, increasing the affinity for oxygenation and trying to increase erythropoiesis, meaning the hematopoietic stem cell producing normal red blood cells, but it can't because it's actually a congenital condition. Okay? So that would activate the erythropoiesis, which is no more the formation of erythrocytes, your eosinophils, neutrophils, basophils, and platelets. Okay? But of course, never to the point of major maturity because it's a congenital condition. Now, the problem that they would have is that having precipitated of beta cells and not being able to produce mature cells, having deficit of erythroid, which is the erythrocyte, the patient will have anemia. Deficit of possibility of neutrophils and basophils, infections. Deficit of platelets formation, bleeding, and a vicious cycle. Okay? So, but in addition to that, what happens is, and it would happen in every single disease process, that when the erythropoiesis is deficient and the patients would have immature cells outside in plasma, if I tell you that the mature erythrocyte has to have the biconcave form to be able to fit the capillary, if I acquire any form, big, banana shape, like sickle cell disease, or any other type of shape which is not biconcave, I am going to form a conglomerate of malformed cells at the level of the capillary, and those cells have a possibility of breaking down and bleeding. So yes, even though thalassemia most commonly is classified as a microcytic hypochromic anemia because the iron molecule is in the periphery and cannot be entered and utilized for the cell, because of the amount of immature cells that are formed outside, and entered the capillary properly, there's also hemolysis. And you might read in your books, and it's not wrong, but I won't ask you that way, that thalassemias could also be acute blood loss anemias because of that major breakdown or hemolysis of immature cells in the capillary, putting them as well in the classification of normocytic normochromic. But what do you think I will ask? Microcytic, hypochromic, right? All right, so why hypersplenism? What did I tell you last week that is the function of the spleen? The spleen is getting rid of malformed, granated, meaning broken down, deficient, old red blood cells, anything that shouldn't be there, right? Cleans up. So the spleen is perceiving what? Oh my God, how many immature malformed cells I have? How many breaking down cells I have going through that capillary? High amount, right? So let me start activating the spleen and getting rid of all those. And what do you think is the consequence, as I told you last week? Hypersplenism, meaning that activation of the function of the spleen so high to the point that the spleen gets tired, right? And that tiredness is translated as ischemia and necrosis, which is called autosplenia. The spleen doesn't work, it's completely necrotic. And what could be the consequence of that? Even though I'm losing lymphocytes and neutrophils and infection. Infection of what? Haemophilus influenza, streptococci pneumonia, and meningo, right?
So you need to give those vaccines?
Yes, for sure. Okay?
Okay, I need to get
Is that if you do splenectomy or you just?
You could do splenectomy as well. That's one of the
You can live
treatments,
with
but
that.
there is, no other resources available when you have already a necrotic spleen is there for no reason. So, but still, you have to cover the patient for those type of vaccinations because the patients are at risk, not only for infection, for infections have a very high mortality. Okay?
Can you
So-
repeat the vaccines, influenza, meningo?
Haemophilus influenza, so Hib. This is not only for kids. Streptococci pneumonia, so for pneumonia strep, and meningococcemia, like meningococci. Okay. So look at what it can do to the belly because of the hypersplenism. So okay. So we have here the laboratory results, and again, even though, remember, your total iron binding capacity could be normal when this, depending on the stage, mild alpha or major beta, because major beta is not going to be normal. It's going to go. What will be the therapy? So don't give iron, right? Be limited with transfusions, as I said, but the best, the most significant, the most specific therapy for these patients is to try to avoid iron overload, and that only could be done by either plasmapheresis, right? Or you do ionoylation therapy with levodoxime. I'm going fast because you should have listened to this, which I already realized that you did not. Remember that even though I also have it in the PowerPoint and it's in your book, the new guideline says try to avoid over-transfusing the patient, keep the hemoglobin at the lowest level, even though you don't transfuse a normal patient outside already when it's less than 7, right? So keep it at 8, the new guideline says. Why? Because the higher you keep the hemoglobin on these patients, the more probability they would have iron overload. It makes sense, that we have had more cases of neurotoxicity. As I said, splenectomy is a choice, but not when you have hypersplenism. when you already have sequestration of the spleen or autosplenia. It's already necrotic, there's no function whatsoever, you know? So you could do that. And again, the word for iron toxicity is called hemochromatosis. You must know that name. And the treatment for that is chelation therapy. How hydroxyurea works. It is also for sickle cell, it is also for cancer, for leukemias and lymphoma. How does it work? What did I tell you at the beginning? That this type of deficiency of the hematopoiesis or erythropoiesis tries to do. Try to bring back hemoglobin F, which is fetal hemoglobin, so transforming your hemoglobin that is malformed by chain beta in this case, by the mutation and its shape in sickle cell, by having so many blasts in leukemias and lymphomas, and converting those clones or mutation cells into hemoglobin F, which we know that has the high capacity for transporting the oxygen hemoglobin. So the medication that is able to do so is called hydroxyurea. Okay?
So it changes the mutated cells or the clone cells into
Hemoglobin
like,
F.
the
Hemoglobin F.
F.
And also gets rid of, which is another beauty, it gets rid of the clusters. What is a cluster? Remember that I explained to you that when you have large amount of malformed cells
They come together.
trying to go through the capillary, they get together as a mass, as a cluster, and they don't fit, and they go through hemolysis. So hydroxyurea breaks down the cluster, allowing those malformed cells to go through the capillary properly and avoid hemolysis. Okay? Of course, the most significant diagnosis will be bone marrow biopsy, right? And the most significant to cure the disease will be transplant. Macrocytic anemias, remember this is the macrocytic normochromic anemia that the most common factors that are deficient here are vitamin B12 or folic acid, right? Remember that vitamin B12 deficiency is called pernicious anemia as well. Remember that going back, you need to have a factor, right? Present in the parietal cells of the stomach, which is called intrinsic factor, that is necessary for vitamin B12 absorption. So any disease process that could affect the parietal cells, starting from achlorhydria or hypochlorhydria, that means low hydrochloric acid in your stomach, by chronic use of PPIs or H2 blockers. Hypochlorhydria or achlorhydria, so no chloride, hydroxychloride or low. 2, also having stomach cancer, gastric bypass surgery, or the banding. If you don't have enough populations of parietal cells, your intrinsic factor will be low, right? And that could compromise the absorption of vitamin B12. Folic acid, most commonly the presentation of folic acid is a patient that, yes, going through malnutrition, most commonly produced by this alcoholic patient that is not ingesting a proper amount of food. Now, you're going to see also in your book that these patients can have a combination of iron deficiency anemia because they're not eating, right? And also, they're not absorbing properly, but not only iron, but also folic acid. So alcoholic is a major marker for folic acid deficiency. But what else can induce that? Well, chemotherapies. Okay, chemotherapies, if you have radiation therapy into the abdomen because maybe you have pancreatic cancer, not the treatment. It's not the treatment, just creating a possibility, right? Or if you have chemotherapy that can affect, because the majority of chemotherapies are not IV, are PO, and are affecting your absorption or intrinsic factor at the level of the stomach can also induce vitamin B12 deficiency. Autoimmune conditions, even though, as I said, most commonly are not considered chromosomal. So, pernicious anemia, please remember that even though any anemia can give you weakness, can give you pallor, can give you somnolence, diminished attention span, and all that, remember that iron deficiency anemia has a marker, clinical, right? That is no more than pica, right? That you have perception of taste, that the patient takes to eat dirt and painting and ice and all that, looking for the source of iron in the environment. Patients with folic acid deficiency, they have chalosis, which is the broken corners of the mouth. They have dry tongue, they have a geographic tongue, they have macroglossia, dry skin. Even though vitamin B12, folic, even though folic acid can also have the same manifestations, even though, again, as I said, in iron, you can have poilonychia, which is the spoon nails, but that could be present in vitamin B12 and folic acid too. What majorly characterizes iron deficiency anemia is the pica. What majorly characterizes the vitamin B12 deficiency is the neurological manifestations. So whenever you see a patient complaining of paresthesias, meaning tingling sensation in the lower extremities or upper extremities, or having tapetus dorsalis or ataxia, or altered mental status, any kind of neurological manifestation, please think about the possibility of vitamin B12 deficiency. Yes?
The pregnant women who gets the pica, is it also associated to the iron? or
Of
has
course,
nothing
it's associated with the iron. Okay? So, even though we don't do the shielding test anymore, still ask over and over and over in your exam. I don't know why, because it's an old fashioned. But you could check intrinsic factor in serum. But it's, common sense that if you have patients with neurologic manifestations and NCV and CHC high, most likely this is related to vitamin B12. Remember that the amount of folic acid, the amount of vitamin B12 deposit in your liver and your bone marrow is high and remains high for the rest of your life. To be able to deplete that, you must have a chronic disease, meaning that, of course it could happen promptly when you do a gastric bypass, but to be able to deplete the amount of vitamin B12 in your hematopoietic cells of the bone marrow and liver takes years to be depleted. So to be able to replete, you also need years. So most commonly, and this is really important, most commonly you would have this patient taking 100 micrograms IM for 1 week. But look, he continues as maintenance 4 weeks and for life.
Once a month.
Don't choose anything else. For life. So, how are you going to prevent? Or how are you going to educate the patient that already had the gastric bypass or the banding or taking protonics for months and years? Discontinue them, right? If it's possible. The others, they have to add that nutritional deficit. These patients have to have vitamin B12 and folic acid if they have, vitamin B12 for the rest of their life anyways, if they have gastric bypass or banding, okay? And also you can tell the patients to eat fortified vitamin B12, like cereals is common sense that you can have that. And if you like organs,
Fried liver.
liver is also a good source. Now, vitamin B12 can also be given intranasal, the same as the DABP. You can give it intranasally, you can give it IV, IM, okay? So, as you see, you have different routes of administration, but I want you to remember that this is not like Cubans do a 1 week set and that's it. That doesn't work. Maybe for neuropathies it will improve, but to replete vitamin B12 doesn't help. Okay? So what will be the key word here make you think that the patient must have vitamin B12 deficiency even though I'm not providing laboratory values yet?
Bypass.
Bypass. Okay? So when you have a deficiency of a cofactor, iron, folic acid, vitamin B12, even though, of course, if you have iron deficiency anemia, I want you to also follow up iron level, ferritin level, transferring, anti-IBC, but what other factor is common to all? Reticulocytes, to be able to see if the therapy is properly working, right? Now, as I said, it's lifelong therapy. Folic acid deficiency is also macrocytic normochromic anemia, so your MCV is greater than 100, your MCHC is greater than 36. What's the major difference here? Again, nothing relevant. You unfortunately have to check the marker, the cofactor, to be able to see if it's deficient or not. Now, there are risk factors that can make you think, right? Such as alcoholism. So, glossitis, which is the microglossia and the geographic tone, and the red beefy tongue, is present in both vitamin B12 and folic acid. This is not a marker, okay? So how will you treat the patient? With folic acid, 1 milligram. Okay? So why would you give folic acid, which is a very stupid question at times, to patients that are pregnant?
For the
Well,
neural.
first, for the neural tube, right, to be able to be formed properly, so the patients wouldn't have, the babies wouldn't have spina bifida or any type of malformation at the level of the spine. And I already said the lab values and the treatment. So this is a patient that has alcoholism. Even though, listen, even though it's a risk factor for anything, because think about it. If you're an alcoholic, you don't drink, you don't eat, right? So if you don't eat properly, you don't give your nutritional values for iron, for vitamin B12, or folic acid, right? So to be able to, even though alcoholism is more prevalent in folic acid, it could be in any, but what actually tells you that a patient has folic acid deficiency is what? MCV that is greater than 100, MCHC that is greater than 100, was the same as vitamin B12, folic acid level. Okay? Now, the major problem with folic acid is that when folic acid is depleted, it's highly attached molecularly with vitamin B12. So, that doesn't mean necessarily that the patient will have vitamin B12 deficiency, but you don't want to miss, even if the patient doesn't have neurological manifestations, while the patient is getting treated for folic acid deficiency, you must treat for vitamin B12 and backwards. Because they have molecularly a highly interrelationship, and when you're deficient for one, you're deficient for the other. So that's the reason why you see in the guideline or your book that when the patients are deficient for vitamin B12, give them folic acid. When the patients are deficient for folic acid, give them vitamin B12. It's highly recommended, okay? So in this patient, fatigue, difficult concentrating, doesn't tell me anything. He says that he gets 8 to 10 hours of sleep per night, but never feel rested. Well, that could be sleep apnea. He's always insomnia. No medications at bedside. He's alcoholic. No significant past medical history. The sodium is 140, normal. Normal. Glucose is normal. Hemoglobin 9.3, so the patient has anemia. This is low, normal. MCV is high. Macrocytic, normal chromic anemia. Alcoholism, most likely folic acid deficiency. Can I tell for sure that it's not vitamin B12? No. Check that, right? Vitamin B12 level, folic acid level. How are you going to treat the patient? Folic acid 1 milligram, right? Daily, 1 to 2, but you just start with 1 milligram daily, and you add vitamin B12. When your results come back, vitamin B12 is normal, you discontinue vitamin. Okay? Oops. This is super important. How can I also differentiate which is highly specific, and you must know? What other laboratory test can I check in plasma to be able to differentiate vitamin B12 deficiency with folic acid? Not only clinically, the neurological manifestations, not only having the levels of vitamin B12 on folic acid, not only treating randomly, but now let me test the cofactors. These are precursors necessary for the formation or destruction of vitamin B12 and folic acid. So, this is manylene mandelic acid. Okay? Vanillin mandelic acid. So, when the patients have vitamin B12 deficiency, homocysteine level, which you know that is the cofactor when it's low, right? I'm sorry, when it's high, there's an incident for coronary artery disease. So, vanillin mandelic acid and homocysteine levels are high in vitamin B12 deficiency, and vanillin mandelic acid is normal, and homocysteine levels are high in folic acid deficiency. That is a major specific marker.
Professor, metformin doesn't need to B12 deficiency.
That's true.
Metformin.
Metformin carries for
Normocytic, normochromic, remember, you either, as a bone marrow, haven't had time to react because you're having acute blood loss anemia, or you have had plenty of time to adapt, and that's chronic diseases, okay? So, acute blood loss, anemia of chronic diseases, aplastic anemia, which is a malignancy, and hemolytic anemias. Here we have any defect at the level of the erythrocyte that doesn't feed properly the capillary, and hemolysis. Sickle cell, spherocytosis, GP6 deficiency, and you can name it. We already went through thalassemia, major, right? That can induce that as well. Sepsis can induce the transformation of the erythrocytes and produce hemolysis as well. What about urea in CKD? Is it CKD, most commonly normocytic normochromic anemia, due to the fact of erythropoietin deficiency? But what about when you have high levels of uric acid in gout, or have levels of urea in CKD? That is toxic for the cell, and that can induce hemolysis. Chemotherapy is toxic for the cell and can induce hemolysis. Okay? Sickle cell disease, which is also called drepanocytosis. This is no more than as well an X-linked recessive condition that the babies, are born with a malformed hemoglobin, which is the S hemoglobin, a mutation at the level of chromosome 8 to 12. You need to know that. But basically, what happens is that this patient is normal, okay? and has a normal hemoglobin A until the time that the patient is exposed to critical levels of hypoxemia, or that there is a major concentration and the red blood cell changes shape, okay? For example, going high altitudes, going to Peru, Costa Rica, etc. High altitudes or airplanes or high barometric pressures, how do you call it? Skydiving or scuba diving can induce sickling. Infections can induce sickling, so including fevers or anything like that. Pain can induce sickling, even though it's an etiology, it's a sign or complication. Dehydration can induce sickling as well. So any critical stage called any hypoxemic event, any hemoconcentration event can induce sickling. And what happens is that, again, when you have a cell that does not have a biconcave shape, and instead it has an S, put S's and S's and S's on your capillaries. Cluster. And that cluster or conglomerate of cells malformed that don't fit the capillary, that don't have a proper adhesion and flexibility, what happens is that they basically produce a plug, a clot, in other words. So that's basically acts as a thrombotic event. And that's the reason why the majority of the symptoms of these patients is derived from ischemia. If it happens in the capillaries or coronary arteries, the patients truly are having an acute coronary syndrome event. If it happens at the level of the pulmonary artery, they truly are having a PE event. If it happens at the level of the arteries that irrigates the pelvis or the thigh, they can have an ischemic and thrombosis event on the muscles that are targeted for that particular artery. If it happens at the level of the brain, they can have a stroke.
Are they the ones that have priapism? Oh yeah.
If it happens at the level of the penis, they can have priapism. But priapism can happen also in leukemias and lymphomas and multiple myelomas, and I'll explain that. It's the same mechanism. For them, it's called leukostasis. So, what happens here is that patients tend to have complications associated with ischemia. But you know that when you have ischemia, you have an anaerobic metabolism shift. And you have, instead of pyruvic acid, you have lactate. And lactate, or lactic acidosis, produces pain. So their pain is a true pain. And pain induces sickling. So if you don't stop the pain cycle, they're going to have more sickling events. Now we have a new research study that is being approved of putting a morphine pump on these patients because of us. Because we are judging these patients of being in opioid abuse. And it's fine that they are in opioid abuse. They're having pain every time they have a sickling event that you have no idea. Don't judge them. Treat the pain. If they become addicted, that is fine. Tylenol is not going to relieve their pain. It will not. That's the reason why guidelines came out with the pump. Yes?
Isn't there a way to check if you're being a sickle cell episode? Like, if the retake goes up, right?
Yeah. I mean, again, these patients are going to have what? LDH.
Yeah, so it's not that,
I mean, to be able to see the actual shape, you would have to do peripheral smear. Even if they come to you only for that, give it. Give it.
We don't give the products to the providers. They're not gonna get it.
Well, that is, the events are called vaso-occlusive event. Why? Because of the amount of clusters of S-shaped cells accumulated in the capillary, not allowing a good blood supply.
I had a sickle cell patient one time that was the most medications I've ever seen, but she went through in a 12-hour shift 100 milligrams of Delonin via PCA pump per shift. Crazy.
Well, all the vaso-occlusive crisis, what can induce? Let me tell you, the most common presentation is called acute chest syndrome, which is again, how can you differentiate this from an MI, from a PE? I understand that you have to do the same. You have to do troponins, you have to do EKG, you have to do CTA, you have to do everything.
Because isn't it that can really also cause?
Yes, yes. So, as I told you, it can produce an infarction anywhere. I'll go through the spleen in a second. If it happens in the retina, liver, thrombosis. Kidneys, acute kidney injury and acute tubular necrosis. Bone. Can you have osteomyelitis to the point because you have no irrigation? Or bone necrosis? CNS, strokes, MIs, you can name it. Now, what happens to the spleen? The more crisis you get, meaning that if you get this amount of S-shapes at the level of the capillary, what do you think is going to happen? Broken down, hemolysis, right? Can fit. Try all of you at once to pass through that door. You're going to have an injury. That's exactly what happens with sickle cell. So that injury is bleeding. And that bleeding or malformed cells is perceived by whom? By the spleen. You're going to be overworking every time they have a crisis. And eventually, they're going to go through a spleen ischemia, hypersplenism, necrosis, autosplenia, meaning that sequestration, the spleen is there, but it's not acting. These patients as well could benefit at the end with splenectomy. Meanwhile, what can you do? Well, let's start with therapy. Try to always recognize the trigger factor. So since oxygen is a trigger factor, even if the patient is not hypoxemic, give the oxygen. Since dehydration is a trigger factor, IV fluids. Since pain is the clinical finding and a trigger factor during a visual cycle, give them severe pain, so it has to be opioids. Okay? If infection is a trigger factor, even if you don't have clinical manifestations of it, while you're getting the Holters, put the patients on empiric broad spectrum antibiotic and then try to either escalate down, eliminating them, or narrow it down if you're able to find infection, right? Find infection. So treat the risk factors, treat the underlying condition. What else can I do? Remember hydroxyurea? Bringing the S shape, malformed hemoglobin A into an F, higher capacity for carrying oxygenation, so you can do that. Yes.
Can the patient also have the leukocytosis and the elevated test without infection being present?
Yes. Yes. So as I said, because you don't know yet, because these patients, remember, even though they have a congenital disease, nothing to do with the neutrophils or lymphocytes, this is a hematopoietic stem cell that is malfunctioning. So patients can have infectious process and not manifesting it properly. So you're going to cover them first and then eliminate them if there's no true infection. Okay?
Dactylitis, Professor? What is that?
Dactylitis is because if I now have, dactylitis is actually a second finger, but in their case, if they have a thrombosis at the level of any peripheral artery irrigating they can have necrosis. Necrosis of the finger? Yeah. But again, no. But you can have peripheral thrombi events. Have you seen peripheral thrombi events in septic patients? On the toes, most likely? They can have it as well, why not? Okay? But the most common presentation is the acute chest syndrome, highly confused with an MI or a PE. And yes, you do have to do those diagnostic studies to rule out. Okay? So, how do you diagnose this? Of course, bone marrow, but biopsy, but hemoglobin electrophoresis. Basically, you take the blood, send it to laboratory for a first smear, and you can see the S shape of that. Okay. This is no more than exactly what I just explained. So this is going over every single system. What can they produce? They can come in with bone pain due to the ischemia of the bone, right? Or anywhere in the spine. As I said, it's precipitated by the same factors. Alcohol can induce that as well. Acute chest syndrome, again, your chest pain, the same. It could be pleuritic, it could be retrosternal, depending on the organ as target that has been damaged and going through this ischemic episode. You must do the CTA if they don't have, of course, even a creatinine elevated. You must do your troponins and your EKG to rule out the episode and treat it the same way. Okay. Now, as she said, priapism, if the artery that irrigates the cavernosus area of the penis is altered, then the patients would have permanent erection that has to be surgery to be able to relieve that. As I explained before, the spleen can go through hypersplenism, ischemia, necrosis, which is called autosplenia, and in that case, of course, you would have to do a splenectomy and cover the patient for the Haemophilus influenza, strep pneumonia, and meningococcinia as well. What else could happen or could induce the episodes? You know, if you have any disease process can do it. If you have cholecystitis, appendicitis, pancreatitis, they can have any type of triggering event for sickling. Okay, so treat the underlying condition. Something else that could happen as well, when they have several episodes of ischemia through the pulmonary artery, even if they don't have a thrombi event as pulmonary embolism, the higher the events of acute chest syndrome producing decreased blood flow at the level of the pulmonary artery, patients can have pulmonary hypertension. And of course, the consequences of pulmonary hypertension, which would be heart failure, right side heart failure. And strokes. And as I said, if it happens in the brain, strokes. So going through the clinical presentation, look at the most common organisms that they tend to have if they have autosplenia. So these are the most or the highest mortality: strep pneumonia, the Haemophilus influenza, and the meningococci, which is not there, even though they can have the typicals, which are mycoplasms. Aplastic crises, as I said, the more hyperactivity, the more crisis at the level of the hematopoietic stem cell. Sometimes the bone marrow gets overwhelmed and stops working and goes through an aplastic crisis. At that time, the patients not only would have anemia, but they would have thrombocytopenias, they would have neutropenias, lymphopenias, and bleeding, infections, and anemias, okay? And of course, imagine this in pregnancy, how many teratogenic effects can induce to the fetus. I'm not gonna go through this is exactly the same process, okay? So as I said, if it happens in the kidney failure, if it happens in the abdomen, patients can have mesenteric ischemia. Patients can have paralysis and stroke. If it happens in the muscle, in the bone, they can have bone necrosis and immobility. Pneumonias, PEs, pulmonary hypertension, heart failure, MIs, acute coronary syndromes.
They also need to be coagulated, no? Anticoagulated?
Like to put those globes or no?
No.
No. What you should do at that time is avoid the sickling. So as soon as you treat the crisis, the hemoglobin shape is going to go back to bifurcate. Because remember, they are normal. They only go through cycling or cycling when they are having a trigger. If you eliminate the trigger, there's no need to anticoagulate.
So it's just the prevention.
All right?
Okay.
So, now, what else could happen on any patient that goes through hemolysis? Not only in the red blood cell, you have the hem and the globin as protein. Not only you release the breakdown of that metabolism, which is bilirubin, but also uric acid is part of the metabolism of the hemoglobin through hemolysis. So, patients with any type of hemolytic conditions can have elevated uric acid and gout. So, you must check the uric acid as well on these patients, as well as you see jaundice, of course, induced by the hemolytic syndrome. But patients should also be covered with your colchicine and maintenance with allopurinol. Okay? So again, you could see how many damages can be produced having sickling. What else happens here? Hypercalcemia. Because calcium, when the hemoglobin goes through lysis, calcium gets converted into the plasma. If it happens that there's ischemia of the bone, remember that the bone is full of calcium, so the amount of calcium in the bone also goes into plasma, and the patients can have hypercalcemia. And hypercalcemia not only induces altered action potential, right? And a lot of arrhythmias and muscle weakness. But in addition to that, patients can have deposit of calcium at the level of the kidney stone, and renal failure. Now, I know I see. Something that you might find interesting in patients that have any type of hemolytic condition. For malaria, in the cases that you live in Africa, okay, or if you ever go to Africa, these patients are immune to develop malaria because the malaria harbors in the erythrocyte, in the intact erythrocyte. So mature erythrocyte with nucleus, okay? So the problem is that there's so much hemolytic conditions going on that the nucleus cannot be preserved, right? And even the adult hemoglobin, the biconcave hemoglobin at that time is not even getting formed, right? I'm not talking about sickle cell alone. Any type of hemolytic condition when the nucleus is not preserved, okay, the parasite cannot grow. So these patients can go without vaccination to Africa without developing the disease. Now, what's the major treatment for sickle cell disease? Treat the underlying condition. But meanwhile, I do laboratories and I try to find the cause. Since you know the major triggers, IV fluids, pain management, why Benadryl? Pruritus. Pruritus. Now, any toxin that is released at the level of the RBC, doesn't matter if it's bilirubin, urea, anything, any major wasting of the metabolic byproduct of the hemoglobin destruction can induce deposit at the level of the skin and pruritus. You might not see the jaundice, you might not see the frost, but the patients have a lot of pruritus and rash. So it doesn't have to be necessarily Benadryl, but any type of antihistamine, okay? These patients, when they're going through hemolysis, they tend to, even if it's mild hemolysis, another indicator that they're going through hemolysis, this is Cuban, okay? That is described in books. When they go, I remember myself because I was scratching. When they go into a shower with warm to hot water, they release a lot of histamine and they have this major patches of erythema everywhere in the body. Hypoxia, give them oxygen. The same principle for patients with thalassemia major. I forgot the other one. Look at that. I'll try. I haven't done it for a long time. The major guideline, remember that I explained for thalassemia major, the same principle here, okay? The problem is the transfusion is not the treatment for it. When the patients are sickling, yes, they're hemolysis, and yes, they're losing hemoglobin, and yes, the hemoglobin is low, but the more transfusions you give, what do you think is gonna happen? More hemo concentration. And I told you that hemo concentration is a risk factor for sickling. So please, please, please try to keep the hemoglobin to 8. No higher than
Why
that.
vaccinations? Or did you just say that they didn't use take vaccination?
For malaria.
For mine.
Okay? So what vaccination will you give? Strep pneumonia, Haemophilus influenza, and meningococcinia, right? Because why? Because they're going through. Now, if the spleen is completely normal and working properly, especially maybe has had only 1-2 episodes, mild episodes, and they don't have any type of hypersplenism or autospleen, there's no need. Now, let me tell you, you get a sport injury, and you get ruptured spleen, and you get splenectomy, same principle. Same principle. You must be vaccinated. Yes. Okay? I had another question? No?
No, I was just asking if, so if there's no hypersplenism, then you don't have to vaccinate?
No.
Okay.
As long as the spleen is intact,
That's fine.
and hasn't gone through any type of hypersplenism or ischemia or infarction, you don't have to. Still working properly, okay? Now, you can also give gene therapy, highly expensive, bone marrow transplant, which you know that that's the cure in 50% of patients. Why clotrimazole? Clotrimazole, the problem is that that's it's an azole, it's for fungal infection. But the problem is that these patients are immunocompromised, okay? And they tend to have a lot of candidas, like rash and vaginitis, and that could be a preventative factor, but or if you have it, you give it. Fluconazole can be given as well,
Yeah, I wanted to ask you,
but it's not like a routine.
what's the guideline for blood transfusion? Where
The
we
same.
normally don't transfuse sickle cell.
Exactly.
Last the hematologist wants it, and he will specifically say when.
Exactly. The guideline, as I said, never, if the hemoglobin is more than, if it's 8, fine. I understand that transfusion guidelines now in general has changed to transfuse only when the hemoglobin is less than 7, okay? Now, if the patient is having just a mild crisis, that doesn't mean that you're gonna transfuse to keep the hemoglobin at 8. What the hemoglobin is telling you, what the guideline is telling you is that if the patient doesn't have signs and symptoms of acute bleeding and the hemoglobin is 8, don't try to increase it. Because the more you give transfusions for the patient, the more hemoconcentration. What you have to do is check your hemoglobin and hematocrit every 3 to 4 hours, every 4 hours, and see if it changes. If it drops, of course you have to transfuse. You're not gonna keep the patient bleeding and not transfusing. Do you understand? The guideline says, never try to avoid, this is what the guideline says, try to avoid hemoglobin greater than 8, because that can induce hemoconcentration and sickling.
And some of these people live at 6 and 5. 6.5.
Exactly.
They're walking around like
Exactly.
normal.
When the guideline says, okay, yes, you should transfuse at that time, but at the discrepancy of the practitioner, if you think that the risk of transfusing that patient with a hemoglobin at 6 is greater than the benefit, and the patient can induce sickling because of your transfusion, don't do it.
Yeah, because they're not symptomatic most of the time. They're just, they're like in pain and they're sickling, but really the anemia is not the problem.
Exactly, that's clinical practice. But your examination and your guideline says that keep it at no higher than 8. Try to keep the hemoglobin no higher than 8 because you can induce hypoconcentration. Okay?
What about an exchange transfusion? I had one guy that was very hypoxic.
When do you think exactly? When do you think that would happen? You're giving already all the treatments necessary. You're trying to look for the triggering factors you can't find because there are many times that you cannot find it. Okay? You're doing everything preventative, and the patients continue to having the troponins being elevated more and more, or patients continue to have hypoxemia. You have to do plasma exchange to be able to to take out all the amount of sickly cells.
There was a student here when we were doing the bachelor that he had to quit because the stress gave him
The stress can also do that.
Yeah.
Aplastic anemia, this is a malignant condition, okay, that basically the word is telling you. The word is telling you. There's aplasia, meaning that there's no function, low function, of the bone marrow. So there's hypocellularity. Patients are classified as, this is a chronic condition, this is a malignancy, okay? So it's a normocytic normochromic anemia, okay? So as I said, there's bone marrow depression. And the hallmark of aplastic anemia is pancytopenia. Pan in Latin means everything. All cells are low, from hemoglobin, anemia, from neutrophils, neutropenia, from lymphocytes, lymphopenia, from eosinophils, eosinopenia, from monocytes, monocytopenia, from platelets, thrombocytopenia. So you could imagine that these patients are at risk for anemia, infections, bleeding. Okay? So how do you think you would diagnose this? Bone marrow biopsy, besides the fact that you could see it in the laboratory result, right? And how are you going to treat these patients? Transplant. Even though meanwhile, because of the possibility of malignancy, even though you could have other factors. If you're in chemotherapy of another cancer can induce aplastic anemia. You would say, well, how can you treat aplastic anemia with chemotherapy, which is treatment? But it's a different type. There are many types. You could do monoclonal antibodies. You could do immunotherapy, okay, which is azathioprine, prednisone. Okay, you could do cyclophosphamide. You could do thyroxine inhibitors. You could do so many types. But sometimes a group of chemotherapy can induce aplastic anemia. Okay, autoimmune conditions can induce that. Radiotherapies, radiation therapy, infections, major overwhelming infections can induce that, but the most common etiological factor for aplastic anemia is malignancy. So, as I said, anemias, lymphopenias, neutropenias, so that's infection, and anemias, and normocytic normochromic, and patients can have bleeding. So how would the patient manifest? Well, they would have the signs and symptoms of anemia. If they're bleeding, there could be mild bleeding from petechias and purpuras, or microbleedings, up to frank bleedings due to thrombocytopenias. Okay, so infectious processes of any kind. So what's the major diagnosis? And you need to know that. The hallmark presentation, even though all cellularities are low, the hallmark is that the absolute neutrophils are less than 500. Okay? The platelets are less than 20,000. And the reticulocytes, as I said, should be working, right? You're losing so many cells. What should your reticulocyte be? High. So these patients actually have low reticulocyte count. But that happens in any type of cancer as well. Okay, leukemias, lymphomas, multiple myelomas, etc. Okay, so many times, as I said, since the most common cause is malignancies or toxins related to the malignancies, the patients have a history of having had a chemotherapy or radiation therapy from a different cancer. Okay? Now, what would you do, for example, CT brain or MRI? What would you do, spinal tap and analyze CSF, thinking about meningococcemia, right? Because these patients can have any kind of infection. Pneumonias, if they're short of breath, prolonged cough, or pleuritic pain, right? If patients with, now let's go through the liver. What could happen in the liver? In pathophysiology, I explained to you, or another professor, that when the bone marrow is not working properly, or in the child, which the bone marrow is still immature, you have what's called secondary lymphoid organs, right? And the secondary lymphoid organs are your spleen, your liver, your Waldeyer patches of the intestine, and your tonsils. So it's not labeled here in this slide, but why not? Patients can have tonsils enlargement. The lymph nodes could be enlarged. The spleen, the liver, and even abdominal distension due to lymphoids, not only in the mediastinum, but also in the intestine. So those are manifestations of, since the bone marrow is completely aplastic, is not functioning, the secondary lymphoid organs are trying to help, okay? To be able to produce red cells, lymphocytes, monocytes, neutrophils, etc. And of course, the patients are high risk of having any cofactor being malfunction as well, having vitamin B12 or because of deficiency, iron deficiency, anemia, you can name it. Okay? That's the reason why it is important to add those cofactors as treatment. But what is the gold standard treatment for a patient with aplastic anemia? Bone marrow transplant. Okay? What else can you do? As you can see, not only bone marrow transplant, but remember the thymus that is completely atrophic? If your bone marrow is completely mature after the child turns into a 1-year-old, okay? So the thymus, even though it is atrophic, it gets hyperfunctional, okay? And you can give immunoglobulins against that. You could give many type of chemotherapy that we're gonna go in detail. What's the time? 6. For leukemias and lymphomas. But again, tyrosine kinase is an enzyme necessary for the Krebs cycle to produce ATP. So these patients are going through not only aplasia, but if you have any other type of malignancy, what do you think your Krebs cycle is going to induce? Are you going to produce a lot of ATPs and ATPs? It's not going to be, right? So even though it's not going exactly through anaerobic metabolism, the amount of energy produced by the cell will be impaired. So we will target that enzyme. And you will see that one of the classifications of the treatment of chemotherapy will be also the targeting the thyroxine kinase. We can also do immunotherapy, monoclonal antibodies, trying to deplete the immune system not to attack the bone marrow and produce that. We can do it through steroids. We can do it through cyclosporin. We can also use methotrexate, you would see in leukemias and lymphomas. Remember, never give platelets to patients unless the platelets are less than 10,000, applies anywhere. And again, whenever you go through hemolysis, not only you are at risk for hyperbilirubinemia, you're at risk for elevation of uric acid, you're at risk for elevation of urea, you're at risk for elevation of iron, which is present inside of the globin, right? So patients can also have iron toxicity, and you can also give chelation therapy. This is another genetic condition, GP6 deficiency is an enzyme, again necessary as well for the formation, good shape of the erythrocytes, giving you a spherocytosis. This, I'm not going to test you on this, but basically again, look at the big cell trying to pass the capillary. Doesn't fit, right? Same principle goes through hemolysis. Okay. Now, what is direct cum and indirect cum? So basically what happens is that when the patients are going, this is mostly tested, even though it's a test for hemolysis, okay? This is mostly tested when the patients are having the Rh factor, the negative Rh factor, for pregnant women when they have a high risk of having a fetus with positive and rejecting the blood, okay? That is basically tested for hemolysis in that particular patient, but why not use CUMS as a factor of hemolysis as well? Okay, so hematologists use this a lot. It's just for your knowledge. Okay, so again, you would see this exactly the same, which is what I want you to know. The major general understanding and treatment, because otherwise you wouldn't refer anybody to oncology if you were an expert, right? The basic principle that you need to know for any type of hematopoietic malignancy, and this applies to aplastic, this applies to lymphomas, leukemias, and multiple myeloma, is that before you do curative therapy, you must do an induction therapy. So it's like a high dose amount of chemotherapy in combination with either monoclonal antibody or tyrosine kinase inhibitors or immunomodulators, whatever you choose, okay, before you do the major curative therapy or maintenance, okay? So for patients with any type of malignancy, you could choose, you would see a variety in leukemias and lymphoma. But again, you could choose, for example, immunosuppression therapy with either hydrocortisone, salmeterol, prednisone, whatever you choose as corticosteroid. You could give IV, IG, because not only aplastic anemia, but any type of hematopoietic cancer can also have hypogammaglobulinemia. So that means that the immunoglobulins are low, so their ability for them to fight an infection, super low. So why not give them IgG, okay, immunoglobulin. Rituximab, which is the only medication that I want you to remember. This is a thyroxine kinase inhibitor that is the prototype for induction of every cancer. Of course, it's the cheapest. It's induction therapy, induction. You do induction, then you do curative and maintenance, okay? But to be able to decide, for example, to do bone marrow transplant, okay, which is curative, you must try induction therapy first, okay? Yes, because the majority of cancers that we will study, they have a 70 to 80% probability of going into remission, depending, of course, of the type. You would see that in a second. Depending on the type, you would see that they have a 70 to 80% probability of going into remission with induction therapy by itself. Before you decide it doesn't work. You can even have more combination therapy if the rituximab doesn't work, okay? And before you decide to do bone marrow transplant.
So pretty much you make the patient worse first?
You need to deplete your immune system first. And yes, they're high risk for infections and a lot of complications, yes. Before you say, let's do this first, unless there's a child, yeah. Have you seen the patient going straight?
No.
So essentially, that's to prepare the body for
Yes.
what is to come. But sometimes.
Because otherwise, think about it. The bone marrow transplant is going to be rejected if your immune system is actively attacking. Okay? So, rituximab, I need you to remember that. And again, you could do plasma exchange in between, depending on the condition of the patient, and you could do a splenectomy. But remember, induction therapy first, before you decide any type of curative. Okay? And you have a combination of antibiotics that you can choose. I'm not going to ask you specifically an antibiotic until we go through an infection section. But remember, these patients are very, very high risk for infections, you know. And also, you would see that patients with aplastic anemia and leukemias, lymphomas, and multiple myelomas are also at risk if they ever had in their past life, I read this morning in the updates, hepatitis B, that they can have like an activation of hepatitis B when they are with the cancer itself or when they are in induction therapy. So these patients also must be vaccinated against hepatitis B, okay? So, I talked about the COOS and the IgG. Now, anemia of chronic diseases is the easiest because it's a normocytic normochromic anemia, right? So you have your MCV and MCHC within 80 to 100, 32 to 36. And basically what you have to look is and treat the underlying condition, right? So what are you gonna see? Again, MCV normal, MCHC normal, and your treatment is based on the underlying condition. If the underlying condition is leukemias, lymphomas, and multiple myelomas, you're gonna treat them as I will explain you. If the problem is CKD, yes, treat the CKD and the trigger factors, hypertension, diabetes, etc., right? If the patient is in end-stage renal disease, dialysis, I understand, but you also need to give erythropoietin, which is Epogen, right? If the WBCs or also the patient have neutropenias, you could also give filgrastim, which is what to increase the amount of WBCs to avoid infections in the patients. So treat the underlying condition. Okay? Now, what else? So this is a little distracting here because, for example, the longer the chronicity that the patients would have, you cannot compare a patient with CKD stage 1 and 2 with a patient with CKD 5, right? Which is an end-stage renal disease. Even though remains most commonly the classification of normal MCV, normal MCHC, the higher the severity, the underlying condition the patient would have, the more probability of patient going into lacking cofactors such as vitamin B12, folic acid, or even iron. So you might have a combination of laboratory results on the patients at the stages advance, okay? That's basically what it's telling you. So you can have low MCV in severe stages, as well as having elevation of ferritin or transferrin or backwards. So that's the reason why sometimes in clinical practice, when you try to apply what we learned here, it's so difficult because not only the patient has other underlying conditions, but also depending on the severity of the conditions, the MCV values and cofactor values could also change, okay? But unfortunately, for studying purposes, you need to be neutral and learn it as the classification that we went through already, okay? So again, treat the underlying condition, and if the cofactors are deficient, as you would see it in stage renal disease, not only they give Epogen, but they give iron, they give folic acid, they give vitamin B12. Okay? And this is a summary. Okay? Okay, so summary of all the values. So you can take a break.